common hand problems. I'm going to read vignette 54 now. A 43-year-old female secretary who does a lot of typing complains about numbness and tingling in her hand, particularly at night. On physical examination, when asked to hand her hand limply in front of her, numbness and tingling are reproduced over the distribution of the median nerve, the radial side 3.5 fingers. The same happens when her median nerve is pressed over the carpal tunnel or when it is percussed. This is a pretty good description of the carpal tunnel syndrome. You can make a clinical diagnosis. This is a carpal tunnel. But the American Academy of Orthopedic Surgery recommends that wrist x-rays, including carpal tunnel view, be done, primarily to rule out other things, so that obviously is the correct answer. Do wrist x-rays with the carpal tunnel view. Initial treatment is splints and anti-inflammatories. If surgery is required, though, there is another test that has to be done. That's electromyography. If you do not do an electromyography before you operate for a carpal tunnel, the insurance company is not going to pay for that operation because it cannot be justified without the evidence that is presented by electromyography. All right, we move to vignette 55. A 58-year-old woman describes that she wakes up at night with her right middle finger acutely flexed and she's unable to extend it. She can do it only by pulling on it with her other hand, at which time she feels a painful snap. This is the trigger finger. Steroid injections are the first line of treatment. If steroid injections do not control the problem anymore, or the patient is getting tired of having injections done, surgery can be performed to free up the tendon. Now, a variant of the trigger finger is depicted now in vignette 56. A young mother complains of pain along the radial side of the wrist and the first dorsal compartment. She relates that the pain is often caused by the position of wrist flexion and simultaneous thumb extension that she assumes to carry the head of her baby. On physical examination, the pain is reproduced by asking her to hold her thumb inside her closed fist and then forcing the wrist into ulnar deviation. So if this is the affected hand, you put the thumb inside, you close the fist like this, and when you do this motion, the pain is reproduced. This disease is called Dequer vein stenosynovitis. Splints and anti-inflammatories can help, but steroid injection is best, and surgery is very rarely needed for this. Now, these three conditions we talked about, the carpal tunnel, the trigger finger, the Dequer veins, often happen to the same patient, and the patient most frequently is a lady. It's a female. The next vignette we're going to read is something that happens mostly to men, and it tends to be seen on people of Scandinavian ancestry. A 72-year-old man of Norwegian ancestry has a contracted hand that can no longer be extended and be placed flat on a table. Palmar fascial nodules can be felt. This is Dupuytren's contracture. Surgery is the only effective treatment if it is disabling for the patient. We move now to vignette 58. A 33-year-old carpenter accidentally drives a small nail into the pulp of his index finger, but he pays no attention to the injury at the time. 2 days later, he shows up in the ER with throbbing, pulp pain, fever, and all the signs of an abscess within the pulp of the affected finger. This is called a phyllon. It is indeed an abscess. It needs to be drained like abscesses do, but there is some emergency to it. The tip of the finger has very close to little fascial compartments that do not allow for expansion. And so that pus there is going to be under pressure, left there for any number of hours or days. It may necrose the tip of the finger. So look for the answer that calls for surgical drainage to be done right away, not to be done tomorrow or the day after. Now, vignette 59 and the two that follow have kind of funny names, sort of descriptive funny names. A young man falls while skiing, and as he does so, he jams his thumb into the snow. Physical examination shows collateral laxity at the thumb metacarpophalangeal joint. This is the gamekeeper's thumb. It is an injury to the ulnar collateral ligament of the thumb. It can be very dysfunctional, very painful, can lead to arthritis, so typically these are treated by casting. You might wonder about this name. Why is this a gamekeeper's thumb? This is a historical name. It comes from a time when landed estates in England had gamekeepers, people who kept the grounds. Now, the owners were the only ones who did the hunting of the venison and the deer and so on, and the gamekeepers were only allowed to kill rabbits for food. And they did it by holding the rabbit by the ears and dislocating the head like this. And of course, that put the tension on the thumb that leads to this injury that we're talking about. And nowadays, it is referred, in fact, in many places as the skier's thumb, because we see it as a skiing injury primarily. Now, the next two again have funny names. Vignette 60. Two hoodlums grab a purse, woman's purse, and run away with it. She tries to grab one of the offenders by his jersey, but he pulls away, hurting the woman's hand in the process. When she makes a fist now, the distal phalanx of her ring finger does not flex with the others. So you ask her to make a fist, the fist is made, but this one stays like this, like she's making an obscene gesture at you. And that's because the flexor tendon has been damaged. And this is the jersey finger, injury to the flexor tendon. And the next one, vignette 61, while playing volleyball, a young lady injures her middle finger. She cannot extend the distal phalanx. Now, when you ask her to extend, the other fingers do, but this one doesn't. It looks like this. It looks like a little mallet. So this is the mallet finger. So we have the jersey finger injury to the flexor tendon, the mallet finger injury to the extensor tendon. Splinting is usually the first line of treatment for either of these. And then vignette number 62, which is the last of the series devoted to the hand, represents a rather complicated, very elegant piece of reconstructive surgery about which you will not be asked details. But this is the replantation of severed extremities. And you might be the first physician at the scene of such an accident, and you need to know how to handle the finger that was chopped off. So let's read this vignette. While working at a bookbinding shop, a young man suffers a traumatic amputation of his index finger. The finger was cleanly severed at its base. All right, this is the do's and the don'ts. You do not put that finger on any kind of chemical. You don't put it in alcohol or, God forbid, formaldehyde. You don't want it frozen either, so you do not put it directly on ice, either normal ice or dry ice. So what you do is you wrap it, you clean it with sterile saline if you have it available, you wrap it in a saline, moistened gauze, place that on a plastic bag, a Ziploc, and then place that bag on a bed of ice so that the digit is not directly on the ice, so it doesn't freeze. And with that, we move to a chapter on back pain. And as we go about back pain, we're going to review some of the most characteristic types of back pain that we can see and that might appear on the exam. Let me start with vignette number 63. A 45-year-old man gives a history of aching back pain for several months. He has been told that he had muscle spasms and was giving analgesics and muscle relaxants. He comes in now because of the sudden onset of very severe back pain that came on when he tried to lift a heavy object. The pain is like an electrical shock that shoots down his leg and is aggravated by sneezing, coughing, or straining, prevents him from ambulating. He keeps the affected leg flexed, and straight leg raising gives excruciating pain. This is a classical description of a herniated lumbar disc. The peak age incidence is around 45. Virtually all of these are either L4, L5, or L5S1. You do MRI for your best diagnosis, because MRI will show you the extruded disc and the compression on the nerves. And bed rest and pain control take care of most of these. And this is nowadays helped a great deal by the development of a new specialty. Anesthesiologists who now devote their professional efforts to the control of pain. And they can be guided by the MRI and inject the places where the nerves are being stimulated, and thereby take care of the pain for the patient. Now, I have to point out, though, that if a herniated disc is either leading to neurological deficits that are increasing, or it is producing the cauda equina syndrome, then we need surgical intervention. And to remind you of that, let me read vignette 64. A 46-year-old man has sudden onset of very severe back pain that came on when he tried to lift a heavy object. The pain is like an electrical shock that shoots down his leg, and it prevents him from ambulating. He keeps the affected leg flexed. Straight leg raising test gives excruciating pain. He has a distended bladder, flaccid rectal sphincter, and perineal salivary anesthesia. In this particular case, this is the cauda equina syndrome, and this is a surgical emergency. Now we move to vignettes 65 and 66 that present us with other types of back pain. A young man began to have chronic back pain at age 34. Pain and stiffness have been progressive. He describes morning stiffness and pain that is worse at rest but improves with activity. The age range, the stiffness, the fact that the pain is worse at rest, gets better with activity, all of that identify for you ankylosing spondylitis. And X-rays will eventually show a very classical picture called a bamboo spine. Anti-inflammatories and physical therapy are used. I'm going to show you some of those pictures. Let me start with one of these reminders of the important thing we talked about. So if you have a vignette on the exam, which is now showing on the screen, where a patient in his mid-40s has electric shooting pain down the leg, worse with straining, that is a herniated lumbar disc. And here's an MRI that shows the disc herniation. But on the other hand, if a patient is in his mid-30s, has morning stiffness, the pain is worse at rest and better with activity, you think ankylosing spondylitis. And the X-rays will eventually show what you see in the screen right now, the bamboo spine. And finally, if a patient has back pain, I'm going to show it and then we'll read the vignette. Is elderly, has had weight loss, the pain is worse at night, is not relieved by rest or positional changes. This is a metastatic malignancy. So let me go back to reading vignettes. And in fact, the vignette that I now have is that very last one we saw on the screen, vignette 66. A 72-year-old man has had a 20-pound weight loss, and he complains of low back pain. The pain is worse at night, is unrelieved by rest or positional changes. This is metastatic malignancy. If it is advanced, you see it on X-rays. If it is not, the bone scan may show it earlier. At a higher cost, of course, the MRI will always show it. And then we can treat the appropriate primary tumor and treat the metastases as well.